talk about testosterone replacement therapy for men and some things that led up to where we're at now with the FDA, big pharma, and doctor and patient's decisions. So testosterone replacement therapy was approved in the 40s for men with low testosterone due to disorders of the testicles, brain injury, extra female chromosome, or chemotherapy. First approved in 1943 for pellets, then in the 50s for injectables, and then in 2000 for a topical gel. And testosterone prescriptions really went on the rise between 2000 and 2013 when doctors were being really detailed by drug reps that this testosterone replacement for low T could be beneficial for men, both quality of life, well-being, weight, sexuality, energy. And there's studies showing that it led to potentially better longevity. Prescriptions increased by 300 to 600% over a 10-year period, 10 or 13-year period. And then the FDA got involved and pretty much put a nail in the coffin in testosterone replacement and the relationship between a doctor and their patient for testosterone replacement therapy. So let's go over some basics. Testosterone replacement therapy is indicated in men based on either the FDA indication or insurance companies' indications. Let's talk about the FDA indication. The FDA indication for testosterone replacement therapy is for men with low testosterone that's defined by a level generally less than 280 nanograms per deciliter. That's a blood test. That's actually severely low, but it's indicated for those men that have either disorder of the testicles, brain, extra female chromosome, in some case chemotherapy, but not for the indication of low testosterone due to aging. Aging is not considered a disease by the FDA, and it's not considered a disease by insurance companies. Blue Cross of Michigan, I'm based primarily in Michigan, and their policy is testosterone is indicated when the level is below 280, drawn 2 mornings before 10:30 in the morning for men under 50 and men over 50 below 200. That's actually severely low. And they must have symptoms such as poor development of the genitalia, like underdeveloped penis or testicles, gynecomastia, which is breast enlargement, night flashes and hot sweats, which men rarely get, and loss of bone mass and shortened height. They lose height, and secondary female characteristics such as loss of body hair. So this is really, they're saying basically we'll pay for it if they have, severe low testosterone due to a medical condition that we recognize, but not for low testosterone associated with aging. Now, that doesn't mean that you and your doctor cannot use testosterone replacement therapy for age-related testosterone decline. It just means that the insurance companies generally will not cover it. Okay, so but doesn't mean it can't be done. The FDA regulates manufacturing and marketing manufactured products, and testosterone has been manufactured for about 80 years. So let's look at what happened. 2000, Androgel came out, and the Androgel started promoting low T. They had low T commercials for men, low testosterone, and prescriptions went up because doctors became aware of low testosterone in aging men. And they started writing prescriptions for men with low testosterone that were having symptoms of low testosterone, which could be decreased energy and gaining fat, decreased stamina, decreased sexuality, decreased energy, and decreased mood. And the drugs appeared safe. We had numerous studies showing it's cardiac protective and protective in most ways, helps reduce the chance of diabetes. But prescriptions went up, and that brought the attention both insurance companies and the government to say, well, wait a minute here, we're paying for this stuff. Is this really an issue? So in 2013, the FDA came out and said, well, testosterone may cause heart attacks and strokes. Interesting. May cause heart attacks and strokes. So they based that on an article in the New England Journal of Medicine, the Journal of American Medical Association that was since retracted that showed that testosterone caused more heart attacks and strokes in men when in fact it was erroneously published. It was redacted, and there's been over 100 peer-reviewed clinical trials showing just the opposite. The American Clinical Society of Endocrinologists came out with a position paper against that, stating that not only should doctors prescribe this for age-related testosterone depletion, but also there's no evidence showing that it causes cardiac harm. The VA did a study and published in 2016 that showed that men who had low testosterone, these were men in their 60s, 83,000 men followed for about 6 years, up to 14 years, that had low testosterone. If they were treated, they were half as likely to be dead in the next several years. If they were treated than those who were not treated. In fact, it's estimated that if you have low testosterone and you replace testosterone, you get about 10% longer lifespan and health span. But lifespan is not a medical indication. Again, the FDA does not recognize aging as a disease, and and insurance companies are not designed to make you live longer. They're supposed to pay for diseases when they occur. And again, aging is not considered a disease. So what's going on here? Well, we have to look at the history of testosterone replacement. So again, in the 40s, it's approved as a pellet. 50s, it was approved as an injectable. Right about the 60s, there were certain laws put in place that drugs had to not only be effective, but also be safe, and it passed the muster. It's certainly safe. And for years, we found that men that had low testosterone were better off being treated than not being treated. But doctors were pretty much not really tuned into this. They figured, well, I mean, aging is this normal process. Testosterone gets low as we age, and therefore we shouldn't treat it. Well, again, in 2000, the drug Androgel came out. This is a topical form of testosterone. I'm not a fan of topicals, but it's one of the forms that's approved. And something that you smear in your body, it brings the testosterone level up effectively. And it was easy for doctors to prescribe it. Doctors typically like to prescribe non-generic drugs. That's their nature, because they get detailed by drug reps that bring donuts in their office and show them the new data. They go to seminars based on new drugs versus a drug that's been around 50 years. Doctors kind of forget about it. And it's not any standard of care to treat men with low testosterone due to aging, because the FDA never approved it for that. So we have to think about a contemporaneous approach. Now, there's been studies looking at what's the incidence of low testosterone in men. We don't have any really good studies that just clearly state randomizing, looking at men with no symptoms at all or with symptoms, what percentage have low testosterone. I have a large study with about 10,000 people in the Chicago area, about 10,000 men, 18 to 85, found that 36% of the men had low testosterone. Now, they were maybe biased in their selection because they got a testosterone blood test done, but these weren't necessarily men that were looking to have their testosterone checked. So somewhere around 30% might be the correct number. And of that, the ones that had low testosterone, the average level was very, very low, 194. Only 17% were treated with testosterone replacement therapy. Of those with known low testosterone leads to more obesity, decreased muscle mass, decreased bone mass, decreased libido, more urogenital symptoms, more cardiovascular disease, more cardiovascular deaths, about double, and more premature death or less longevity. Yet it's something we don't routinely check for and treat. Looking at the data in 2000 and 2013, that's the best numbers we have, because that was leading up to the time that the FDA kind of intervened to try to get doctors not to prescribe testosterone so often. The number of men that had testosterone replacement as a prescription was 0.5%, about 1 out of 200 men. It went up to about 3% in 2013. And then when the FDA came out and said, hey, we think this causes heart disease, it actually dropped back down to 1%. It's been stable since that time. And this whole thing about testosterone causing cardiovascular disease was actually a myth. It was not correct. When the papers was published, the FDA immediately jumped on and used it as a reason to do what's called a black box on the labeling. Doesn't prevent your doctor prescribing it, but they're aware that the FDA says this might cause heart disease. And when that study was retracted, the FDA didn't change their stance on it. They generally do not reverse regulation. That's just a nature of the executive branch of government. When they make regulation, unless there's a presidential order or a judicial order, they stay, for a long time, regardless of the outcome to people. So testosterone replacement therapy, the additional issue is for insurance. A lot of times they get a question from men, why won't my insurance cover this? Well, they will under certain circumstances. So first off, I'll use Blue Cross of Michigan because that's a big one in our practice. There has to be 2 levels done before 10:30 in the morning. It's got to be extremely low. Less than 280 for men that are less than 50, and less than 190, less than 200 men that are over 50, which is extremely low. If it's that low, you already have probably diabetes and are usually obese at that time. And then they've got to have symptoms such as breast tenderness and gynecomastia, loss of height, loss of hair, underdeveloped genitalia, and hot flashes and night sweats, which generally there's men that have that. They have a clear endocrine problem. They should be worked up from that. They might have a tumor in their brain. They might have an extra female chromosome. They might have a testicular injury. So that's a small group of men that definitely need to be worked up and treated. But there's a whole large group of men that don't have those symptoms and don't have such severely low testosterone. And today, 99% of them aren't being treated, maybe a higher percentage than that. So this is a big, disservice to men in our country for a drug that's pretty cheap, that you can pay for on your own, that your doctor can prescribe, that reduces cardiac mortality substantially, may extend your life about 10% in men with low testosterone. So I think this is something we really need to realize, that as physicians, we're underdiagnosing low testosterone because there's the assumption that the insurance company doesn't pay. In other words, if it's not free, men can't have it. You can get stuff that's not covered by your insurance. Your doctor is totally allowed to prescribe it in the right setting. It is a controlled substance, so it's got to be under a doctor's guidance or a provider's guidance. guidelines, so can't just be taken without a prescription. In the guidelines for what level of testosterone determines which men will benefit are quite vague. So we look at studies comparing different specialists. Doctors have the most expertise in hormone replacement would be endocrinologists. This is a residency that doctors undertake to specialize in hormone replacement therapy, and they generally go by symptoms rather than by an absolute level. In fact, a large study showed that the most likely men that had testosterone levels that were considered normal that got replacement were by endocrinologists because they had symptoms of low testosterone, even though their testosterone levels were in the so-called normal range, because we know that normal range is not really helpful. It just means that that's where 99% of men fall. Additionally, the Mayo Clinic Proceedings published international consensus guidelines for treatment of low testosterone in men with symptoms of low testosterone. And one of their position statements was there's no blood test that accurately predicts which men will benefit from testosterone replacement therapy. So if you have symptoms of low T, we've talked about this before, the symptoms, one of the only ways you can tell if testosterone replacement is going to work is to try a testosterone replacement and assess your symptoms. And a good example would be high blood pressure. So somebody has borderline high blood pressure, and they're starting to get some hardening of the arteries and some things that might be associated with high blood pressure. We diagnose it with a blood pressure cuff, and we give a medication. And what do we measure? Do we measure the medication in the blood? No, we measure the blood pressure. Okay. So measuring the testosterone level to determine efficacy is probably a fool's game. There's not any level that predicts who will respond. And we don't really know what the ideal level of testosterone for men is. Now, we could have taken everybody's testosterone level when they're 20, when they're the healthiest, so when it peaks is about 20 years old, and say that's probably where it should be. Well, that would even be a false sense of security, because when you take exogenous testosterone, in other words, testosterone from the outside, a shot or cream or pellet, your body makes something called sex hormone binding globulin, which is like a little sponge that binds up this testosterone that sees as outsider. So maybe that your pharmacologic blood level needs to be a little higher than the physiologic blood level, which we see commonly for both men and women. Additionally, when insurance does pay for testosterone, they don't pay for enough testosterone replacement to get you to a therapeutic level. They pay for enough testosterone replacement to get you to a level where you're no longer severely hypogonadal or severely low testosterone. For example, Blue Cross of Michigan will pay for 50 milligrams of injectable testosterone every 2 weeks. Now, the standard dosing in North America that we see is 200 milligrams every week, or 100 milligrams twice a week. So 200 milligrams a week, say on average. And the Blue Cross says, well, we'll pay for 25 milligrams a week, but you give it 50 milligrams every other week, which is just too low of a dose, but it will get your level from 190 to say 260 or 70 or 80. So that's kind of their stance on it. It just gets you barely there. And we know that's not going to make a man feel better. So I think that accept the fact that everything that is related to your health is not going to be free. You may have to pay for, a gym membership. You might have to pay for, a sauna if you're trying to do some longevity stuff with sauna. You might have to pay for healthy foods. You might have to pay for, meditation classes or yoga, and you might have to pay for some of your medications. We see this with some of the weight loss drugs, which are very effective. Insurance companies don't see obesity as a medical disease, so they might pay for them. And low testosterone due to aging is not considered medically necessary, but the benefits are fairly clear, at least in my opinion. I've written a book on this, and the book is called If Your Testosterone is Low, You're Going to Get Fat. This and 17 other things the FDA does not want you to know about testosterone. I published that, I believe, in 2017. This is basically a review of the medical literature supporting treating testosterone that is low, at least low symptomatically, with testosterone replacement therapy, even if it's low due to aging. Now, again, there's causes of low testosterone that require a more thorough medical investigation: extra female chromosome, damage to the brain, damage to testicles, and chemotherapy. But I'm talking about the fact that testosterone declines as we age, some men faster than others. And if you are the man that has lower testosterone, you don't treat it, your likelihood of long survival does diminish. Your likelihood of heart attacks and cardiovascular disease, strokes, and heart attacks goes up. So in summary, low testosterone can be treated. The FDA does not authorize the use of testosterone for low testosterone due to age, but the FDA regulates manufacturing of drugs. It does not regulate the practice of medicine in any way, shape, or form. This is called off-label prescribing. It's quite common. So a drug's FDA approved for one thing, it could be used for another thing. And doctors are expected to use evidence-based medicine, which in one case might be the Society of Clinical Endocrinologists. They have some statements on this, and they don't agree with the FDA's stance that it should not be used for aging-related testosterone deficiency. So we can say that's probably a good rule of thumb. There's numerous medical societies that have come out against the FDA's position on testosterone indications and the fact that it might cause heart disease, which it doesn't. But the FDA does not dictate